passionate about women's health and has served as faculty on the Iowa Alliance for Innovation on Maternal Health and is currently co-chair of the IDHHS prenatal subcommittee, and she's always looking for ways to improve the quality of and access to patient care. So with that, I will turn it over to Dr. Jochims.
I recognize some faces. I brought my little note cards, but I'm notorious for not looking at them until later. So if at the end I go back and say, oh, I was supposed to tell you this and this, that's probably why. I am very open to interrupting. I'm an interrupting kind of person. So if you're like, ooh, I have a question about that, you can ask me. I can't guarantee I'll have an answer, because one thing you'll find that's probably a little bit disappointing is that we probably don't know as much about hormones and our health as we'd like to in the scientific world. But a lot of it is going to be a little bit about more the studies that we have are about like postmenopausal supplementation, but we just talk a little bit about what hormones and kind of some of the main ones we've got. So mainly I'm going to talk about sex hormones, and we'll talk about what those are, how they affect our body, and what are the risks, I should have said, and benefits. There's lots of benefits too. Risks and benefits of supplementation. So the reproductive hormones, also, people say, what are the sex hormones? Estrogens, progestins, androgens, which is basically testosterone. There's like one other one. So estrogens in the body. So there are 4 what we call endogenous, or like estrogens that come from our body, not coming from plants and animals and other things, but 4 that humans have. Estradiol, E2, is the one that you maybe are familiar with if you've seen in like birth control and patches and hormone supplementation. A lot of that is estradiol. And then this last one, E4, that's pretty much only made in pregnancy, so we don't really see that or use it or make it very often. Supplemental estrogen. So this is a lot of stuff. Endogenous meaning things that come from in our body. Synthetic meaning we made it in a lab. Plant-based, to be honest, plant-based is pretty much also kind of synthetic, because all the ones we get from plants, you started with it from a plant, you take it to a lab, and you add chemicals and subtract chemicals until you synthesize what you want. So it's basically all synthetic versus what we get. So these are just some of the different common or different ones that are available in the forms. One of the most common that we use is conjugated equine estrogen. Conjugated estrogen. So conjugated equine meaning horse, it literally comes from pregnant mare urine. So that's where we get a lot of it. This is really tiny and you can't read it. It's really just here to say, like, there's a lot of options. So if you go to your doctor and you're like, I need hormone replacement, I need some estrogen, there'll probably be a lengthy discussion in terms of what kind of estrogen and how do you want to get it to your body. So our skin is really cool. It's an organ in our body, and it's this nice barrier protecting us from the world, but it actually is also absorptive. So anything that goes on your skin goes in your skin. And so actually transdermal, whether that's a patch or a lotion, is one way to absorb. Oral, you can take pills. Vaginal, you can do tablets in the vagina, creams in the vagina, rings in the vagina. You can do injections into the muscles. There's a lot of different ways to get supplemental hormones. So estrogens, what do they do in our body? They're anabolic. So that's kind of when you hear anabolic steroids, like you did steroids for muscle mass growth. Well, yes, testosterone is one of those, but estrogen actually is also that. So increased bone muscle mass, bone density, that sort of thing. That also helps explain why when you get decreasing levels of estrogen later on in life, you see decreased bone mass, decreased muscle mass, all that sort of stuff, so working the opposite effect. Decreases the stiffness of tendons and ligaments. This is good. It makes us stretchy and bendy. That's also why in pregnancy you get extra estrogen and you get extra stretchy, because you have to make room for things to both grow inside and make their way out. Affects brain function and memory, stimulates neurons, lots of things. Estrogen does a ton in our body, and a lot of it we only sort of kind of know. We only touch the surface. Reduces LDL, which is your bad cholesterol, increases HDL, which is your good cholesterol. It increases melanin, that's the pigmentation of your skin. Sometimes people like that. We're all liking being tan. However, a lot of times this is going to be the less kind you like when you get the mask of pregnancy and you can get black eyes or mustaches. I distinctly recall being pregnant and having my dad say, do you have a black eye? I was like, no, I don't have a black eye. I have extra melanin today. It also causes increased salt and water retention. That's something none of us probably really like very much. You can also think about sometimes maybe on your period, you're like, I feel so bloated. You have a lot of extra estrogen around and you're retaining that salt and fluid. increased vaginal lubrication, wall thickening, and then increased libido. That actually works in conjunction with testosterone, so it's really kind of interesting. I'll talk about this a little bit later, but you can't really have one without the other and get the effects that you desire. This is just a pretty picture that I found on Up to Date that shows in this side's talking about the male body, that side's the female body. These are just like various places where estrogen has an effect. So basically it affects everything in your body is a nice way to think about it. So then the next one we have are progestins. So progestins come in a bunch of different classes. So in our body, the endogenous is progesterone. That's what we have. That's it. We don't have all kinds of super fancy things. The natural form is made from plants. They're made from Mexican yams. And like I said, it's when you're like, I want the compounded, all natural kind. Yes, it starts from a yam, but then it goes to a lab and it gets chemicalized and turned into what we want it to be, progesterone. Then we have the synthetic preparations. So kind of first to fourth, you can talk to your doctor about it later, but basically older to newer. Truthfully, I think I use some out of all of these categories for various reasons. Most of these you're gonna see used in birth control. They're mostly used in different preparations for birth control. And interestingly, their side effects are a little different. So here we talk about progesterone. So this is basically, I said progestins in the body, but I'm really talking about progesterone. I'm really talking about the one that your body makes. These are the things that it does. So basically, an unbelievable amount of things in pregnancy that you could do an entire presentation on just that. Increased urination and decreased salt retention. So this is good. This is like that second half of your period where you get the progesterone and then you get to like de-bloat, or second half of your cycle, I should say. Helps relax smooth muscle. That helps in pregnancy, helps prevent, so it's one of the mechanisms they believe that it helps with preventing preterm labor is it relaxes the uterus and decreases contractions. Lobulo-alveolar breast tissue growth. What that means is milk ducts. It helps you grow the tissue that makes milk in the breast. And then it actually, unfortunately, can lower HDL and have androgenic effects such as, the facial hair or male pattern baldness, things like that. But those are the synthetics. So that's kind of why I put that in there. That's one of the interesting things about the progesterones is that the endogenous and the ones we make actually do different things within our body. So most of the reasons that we keep going in these generations is they actually do less and less and less of those androgenic things that people don't like. Acne, oily skin, that sort of thing. So talked about the cycle a couple times. I stole this, I Googled this. Don't get me in trouble with copyright. Everything else is like legit except I stole this off the interwebs. So I thought this is just a really nice picture. So it talks, I can't really point to it here, but this blue line, so the red in the beginning is your period, that's when your cycle starts. Then this blue line, that's the estrogen going up. So then we get the LH surge, you ovulate, and then you get the progesterone here. And kind of one of the interesting things is, you're like, do I really care about that? Probably not, but when we talk about all the effects that those hormones do and how they affect our body, and then you look at how they work in a cycle, it sort of starts to make sense about why you feel different ways during different parts of your cycle. Androgens, testosterone and androstenedione, I think I had to look up how to say that like 3 times and I already forgot. I don't really know much about this, other than it apparently is an androgen, but nobody really talks about it, uses it, or does anything with it. So mostly we're talking about testosterone. So protein synthesis, growth, muscle mass, bone density, virilization. So that's the, voice lowering, getting facial hair, underarm hair, hair down the belly, increased oily skin, acne, loss of scalp hair, increased libido. So there is like one good thing in there, which I would say, that's when I do encounter patients that are like taking testosterone supplements, it's more like energy and increased libido is more what they're looking for in terms of their supplements. So now we'll talk about uses a little bit. So FDA approved uses, testosterone, there's nothing that's FDA approved for testosterone for females. And then estrogens and progestins, contraceptives, that's the most common place we see it. They're actually approved for use in treatment and prevention of osteoporosis. And then in menopause, they're specifically approved for hot flashes and genitourinary atrophy. So that's just that, basically the thinning and the breakdown of that vaginal tissue that can cause pain with intercourse, more frequent UTIs, that sort of thing. Bioidentical hormones, this is something that I think is really popular And I know it's done like in various, clinics and places around here. There are some compounding pharmacies I've used that can do this sort of thing. So we don't have to get into the details of them. None of them are technically FDA approved. So there is data on them. It's not that there's no data, it's just a different process for approval and use. Again, when we talk about finding something natural, I always point out, yes, it did come from a yam, but it went through a fair amount of processing before it got to you. So menopause. So median age, 51, although it's not abnormal until you're under 40. And I don't need to share how old I am, but 41 doesn't feel normal to me. I don't anticipate or hope to go through menopause at 41, but it's real and it's approaching. And so at first when I kind of put this together and they were like, oh, the age group, and I was like, oh, well, I don't know if I really want to talk about menopause. That's, like super far away. And then I was like, oh no, it's not. When we get into the data, it's actually a little interesting because one of the overall takeaways is basically the sooner you start, probably the better in terms of if you're going to do hormone supplementation around the time of menopause. So definition, 12 months without a period. So a little tricky for people who maybe have had a hysterectomy or something like that to use that as a definition for when you have menopause. So there are some lab hormones and things that we can check to kind of know, but a lot of it is just really symptomatic based. So it is affected by genetics and lifestyle, as in, so if you have a hysterectomy but they leave your ovaries, you still go through menopause a little bit earlier than somebody else who didn't. If you are a smoker, you go through menopause a little bit earlier than somebody else who isn't. If you're, genetics, family history, if everyone in your family goes through menopause at 45, you're probably not gonna go through it at 55, you're probably gonna go through it at 45. So this whole next section, I'm gonna click through kind of fast. Because I want to leave some time at the end just to chat about a few other things, but it's just talking about what data is there. Because when people come to me and they say, I want to do hormone supplementation, or I actually don't say that. They say something's wrong with my hormones and I want to do something about it, and I think what I want to do is more hormones, which is reasonable actually. They ask what's safe. And then my answer is usually this really convoluted, nonsensical thing that leaves them more confused than when they got there. So the data here comes primarily from 3 trials, and I am a very science-oriented person, so I actually made my sister look through this, and she's like, that doesn't make sense, you need real words. So she kind of fixed some stuff, so hopefully it makes sense. So WHI, let me pull these out so that I can remember exactly. Don't judge me right now. Okay, Women's Health Initiative. So that's a clinical trial, also an observation study, and also was community prevention. And most of what they used, so this is his first trial, WHI, that's the biggest one. Most of what they used in there was the conjugated equine estrogen and a synthetic progesterone called medroxyprogesterone acetate. And then they compared it to placebo, so people who were getting nothing. This trial came out, and everywhere, everyone was told, hormone supplementation is bad. You're gonna get breast cancer, you're gonna get endometrial cancer, you're gonna have a heart attack, no good. And as they went on and did secondary studies, they found a lot of different information. So what you'll find out is we're gonna talk about that, because initially in this study, they took this really wide range of women in a big age range, and some of them were recently postmenopausal, some of them were way postmenopausal, they had different risk factors, and when they really sorted that data out, it's actually not quite as clear cut as bad as they made it sound. And so there was a big chunk of time, even when I started training like 10 years ago, where it was like, we don't do estrogen. And so you will encounter a lot of providers probably who are still, myself included at times, who are still uncomfortable prescribing people with estrogen and progesterone. So the HERS trial was the Heart and Estrogen Progesterone Replacement Study. So this was a study with women who had known cardiac disease. And so they said, well, does it really affect them? Let's see. And then the KEEP study was the Kronos Early Estrogen Prevention Study. So these were younger people in the 45 to 55-year-old range. So hot flashes. I really like this picture. So both estrogen and progesterone work really good at getting rid of hot flashes. So if your hot flashes are life-altering, that's probably what you want. 80-90% reduction in symptoms, and it works better than anything else we have. If you are not a candidate for estrogen or estrogen and progesterone, and or you just really aren't comfortable taking them. There are some non-hormonal options. This is the only non-hormonal part of this whole talk. I just felt like to do it justice, I should stick them in here. So there are some other options for hot flashes other than those, even though they are what works the best. Mood. So there's really not much on estrogen and progesterone together, but there was a study with estrogen only, and it showed that it would improve mood, so this is good, but mostly in perimenopausal women and not postmenopausal. So it mostly helped when you're in that transition period, not so much like, hey, I'm 5 years postmenopausal and I'm really crabby, and can you give me estrogen and will it make me feel better? So there's that. Endometrial cancer risk. This is a big one. Doctors will talk about this a lot. If you have a uterus, you need progesterone with your estrogen. So estrogen, as we talked about, being like a growth factor, it makes the lining of the uterus grow. The lining of your uterus is your endometrium. The more it grows, the more mistakes it makes. The more mistakes it makes, the more likely it is to turn into cancer. So anybody with a uterus should not be on only estrogen, because you're gonna end up, like, it's actually like pretty quick, like you will end up probably with a problem. If you, however, add progesterone to it, you almost have no risk, which is really, really cool. And if you do that and you start younger, then you really don't have any risk. So most of the data, like moving on, basically says if you have a uterus, you need progesterone with your estrogen, and if you don't, you're probably fine just to do estrogen. Vaginal atrophy, it works. It fixes this problem. Whether you do oral or topical, meaning vaginal, it works. Skin, so this, there's been a few studies that said it didn't make a difference. There's been a lot of people who have probably said it does. But it may improve the thickness and collagen and wrinkles, and that is sensical from a science standpoint when you look back at what does estrogen do, and we talked about how it makes things like all nice and stretchy and all that sort of stuff. So eyes. So actually there was a study that estrogen reduced risk of cataracts, and that it also helped with dry eyes. Also, estrogen alone was a little better than progesterone. This will kind of be a theme. And that starting younger was better than older. That will also be a theme. Sleep. Estrogen improves your sleep if the problem is hot flashes and mood disorders. If the problem is restless legs or sleep apnea or something else, it's not going to help. And so that's one where I have somebody, if they're like, I'm having trouble sleeping, it's really important to try to figure out why. Bone loss and fractures, we talked about this. Absolutely, it helps. The interesting thing here is, this is interesting. Estrogen only reduced your fracture risk overall. However, there was a very small increase in hip fractures if their treatment was started early, and this is like the only outlier. That's a little weird. So that's one of those things where we kind of take it with a grain of salt, and we're like, well, it was a big study, but it was one study. Is it true or is it not? Estrogen and progesterone together reduce fracture risk overall. So this is one where the progesterone seems to have had some added benefit. Osteoarthritis and joint pain. Estrogen, there were some studies that said, yeah, they reported like less on their pain scales is maybe helpful. This is the only one that has long-term use as some kind of benefit. Everywhere else you will see long-term use leads to less benefits. And again, estrogen and progesterone, same thing, more likely to get relief. You can interpret that as you will. I don't like that, it's not very sciencey for me. Recurrent UTIs. So with estrogen supplementation, so there is reduced risk of UTIs with vaginal application of the estrogen, not oral. And the thought process behind that is basically that genitourinary atrophy, so that thinning of the skin and all that can happen with the estrogen depletion, is more directly affected with the topical estrogen, the local estrogen. And then estrogen progesterone trial and the HERS trial made no difference, but however, again, that was an oral supplementation, not a vaginal supplementation. So I think it is reasonable then to say if you're having lots of UTIs that some vaginal estrogen would be helpful, and that is something I prescribe pretty regularly actually. This was interesting. I didn't know this till I put this presentation together. Colon cancer risk. So there's one study that said that there was no difference if you're on estrogen only. Then the WHI, when they re-looked at their data, so I kind of talked earlier that when they re-looked at the data, they decided to not do like 40 to 70-year-olds all grouped together. They divided them out. When they did that, and they did a shorter period of treatment, 5 years only, and they started it earlier, closer to menopause, 50 to 55, that there was actually reductions, and there was reductions in both of them, which is really pretty cool. Cardiovascular risk. So this, I think, is one of the coolest things. So this is one of the things that when they looked at everybody all together, so this 50 to 79 years old group, there was increased risk of strokes, DVTs, cardiac things, and that's what came out of this study in the beginning. That's what was everywhere in the news, and that's why everybody stopped prescribing estrogen and progesterone for folks. Then when they looked closer and they were like, wait. What if we start this hormone supplementation more close to the natural point in time where those hormones went away? What if we don't wait 10 years and then start it? What if we start it when you first go into that peri or postmenopausal period? And what if we just do it for a little while and we don't do it for 10, 20 years? And then they found that was a really good idea. So less CHD cases with estrogen only, and then again, estrogen, progesterone, same thing. It depends on when you start in relation to your when menopause is occurring for you. So, they saw a little bit more here, even in that young group, but much less than what they saw in that older group. So for heart, ideally, estrogen alone is better than estrogen with progesterone. If you are talking with your provider or thinking about starting something like this before you do it, there's a couple risk calculators that are useful. This would be one of them. So we just plug in all your numbers and things, and we look at, okay, how likely, are you already? What's your baseline risk? And if your baseline risk is really high, maybe this isn't the best plan. Maybe we need to look for alternative options. If not, then we go lower. This is really interesting. It says up here, MHC okay, choose transdermal. Transdermal is something stuck on your skin, absorbed through the skin, dermal meaning skin. There's a lot of medications actually in the world that affect us differently if they're on our skin versus in our mouth, because anything taken by mouth goes into our stomach, dissolves in our stomach, and goes to our liver before it goes anywhere else. And our liver breaks down things, changes things, metabolizes things. And so some of these changes that we see in risk and benefit of medications really are different depending on where we take them because of what our liver does to the stuff we eat. Stroke risk. Here's another one where you see that progesterone be a little bit naughty. So estrogen, if you look at the whole big group, so we're talking about starting it when you're 70, 65, you've been 10 years postmenopausal, or you continue it 20 years and you're 70, not such a great idea. However, if you start it when you're a little bit younger and you use it for a shorter amount of time, probably actually carries some benefit. This is one of those where if you have progesterone on board, that gnarly progesterone is a little bit of a pickle. I will tell you, most of these that are this WHI, they used medroxy progesterone acetate, and that itself it's like kind of what's in Depo, is not used as much anymore because it's probably not the best progesterone. So I'll be really curious in the future to see if they repeat studies like this using some different formulations of progesterone, and that I would not be surprised if maybe they got a little bit different information there. So gallstones, isn't this cool? So gross. Estrogen, unfortunately, increases your risk of having gallstones, and that's not a surprise. Females that are fertile and 40, that's like a little saying we use about who gets their gallbladder out. Fertile meaning lots of estrogen, female 40s meaning you're premenopausal. So it's not surprising to me that getting a little extra estrogen later on does the same thing it does to you when you're younger. Weight BMI, much to many people's disappointment, it did not seem to make any difference. Type 2 diabetes. This was new. I learned this too. I don't know. Did you know this, Holly? I didn't know this. This is new. So there were studies that actually said, multiple studies actually, that it reduces your risk of type 2 diabetes, estrogen progesterone supplementation. Again, I'd be curious to know what estrogen alone does, but there's no data to say, so I don't know. But NNT means number needed to treat, and that just means like for every so the HERS trial said that for every 30 people that are treated, one less person will get type 2 diabetes. And then this trial said, well, for every 100 people that are treated, one less person will get type 2 diabetes. Dementia. Yeah, so this is interesting because we talked earlier about how estrogen affects so many different things in the brain and neurons and things like that. And I'm really not using this at all, so no, it affects, all these different things in the brain. And so people who go through menopause start to feel like, oh, I'm getting more forgetful, I'm having trouble, and even pregnancy, people talk about pregnancy brain. So there was like really big hope that this would be really, really helpful, and all of the studies basically said no. Some of them even said it makes it a little bit worse, but again, that was sort of that timing thing, when we start older, that's apparently not the best plan. Sincere apologies to anyone who's 70, it's probably not the best time to start, sorry we didn't give this talk 25 years ago. DVT, so deep vein thrombosis, blood clots in the legs, pulmonary embolism, blood clots in the lungs, we're just talking about clotting. Unfortunately, both of these are saying it's a little more likely to happen. That's not super surprising either. We see those more commonly in pregnancy, other high estrogen states. That's a pretty common factor. So this is one where I think talking to your provider about your personal history and your family history would be important, because if you're otherwise low risk, it's not something that would deter me or hopefully anybody else from giving you, access to these medications. But if you were high risk, it would maybe be something at least worth thinking twice about, or potentially even just keeping a closer eye on. Ovarian cancer. So there's two versions. They both come from the WHI study. However, when they looked at everyone together, they actually said no increased risk. And then when they did that secondary analysis, they said, there probably is maybe a teensy bit of increased risk. But there are multiple organizations that said, do not let this deter you. That's a very, very, very small increased risk, and potentially, again, this is a secondary analysis of data. So, but potentially there is. That would be another one where I would probably say hey, what's your family history look like? Breast cancer, we did skip it. Okay, so before you do treatment, we also talk about calculating breast cancer risk, because that's probably a big one that a lot of people talk about. What's, could this increase risk for breast cancer? And there was recently a big thing about how during the time that you're on birth control pills, there can be a slightly increased risk of breast cancer from hormones. So these guidelines I think are really interesting to me, because they come from the Endocrine Society, and they say if you calculate someone's baseline risk and it's high, meaning over 5%, that we should not treat them. However, if you have somebody that you're not talking about hormone replacement, but you calculate their breast cancer risk and you maybe want to give them something to prevent breast cancer, then we consider 3 high. So if you aren't talking about hormone replacement, we're like, ooh, at 3 you need to intervene and do something to help decrease the risk for breast cancer. But if we're talking about replacement, then we suddenly say, okay, now at 5. So I do know that some people kind of use 3 instead of 5% as a cutoff, just because they're thinking, well, if 3 is high enough that I need to give you a medicine to prevent breast cancer, then it probably should be high enough that I shouldn't give you a medicine to increase your risk. Summary. So this is kind of the fun takeaways, I think. It's basically who should be getting treatment, right? Who's the best candidate here? So people who are symptomatic. Even though that we did see some benefits in there, we talked about maybe a little less colon cancer risk and things like that. I don't know that any of those benefits are strong enough at this point in time for us to say you should be on it to protect you from colon cancer or something like that. So we wouldn't really necessarily offer or recommend treatment to anyone who's asymptomatic. So symptoms, less than 60 when you start, less than 10 years from menopause, and ideally you don't use it for more than 5 years. And that category is incredibly safe and maybe even helpful. And I think that's really different from a lot of the data and comfort level that people have had for a long time. What do you use? The lowest effective dose. Considered transdermal, so that's what we're talking about, patches actually might be a little bit safer and better than the oral formulations. Unfortunately, maybe a little extra costly too, because pharmaceutical companies are very smart. And then using progesterone, particularly if your uterus is present. And I did make a point to point out the micronized. So micronized just means it's in little teeny tiny bubbles and beads, so that it has more surface area and is absorbed better. But specifically, using not those synthetic types, specifically that medroxyprogesterone that was unfortunately used in all the studies that the data came from. Then there's a few things where it's like, hey, who are the people that we just really probably shouldn't be giving hormones to? So personal history of breast cancer, high risk endometrial cancer, personal history of a blood clot, and then some of these unexplained vaginal bleeding, just because we need to figure out what it is first, but active liver disease. Some alternative therapies. So I put them up here because I know people do it. I have lots of patients actually that take black cohosh. Isoflavones, that's basically soy. And so that actually I think was really popular for a while because a lot of people were like, you can't give, everybody soy. There's too much estrogen in it and you're gonna, whatever. Well, it's true. There is some plant estrogens in there, but you'd probably have to intake an obscene amount of soy products before you noticed concerning effects. What about perimenopause? Really disappointing. There's no data. I tried really hard. There's no good data, at least at this point in time, to really talk about that. But I do really think that they will be moving more towards, when we look at those timelines and that, moving towards maybe initiating more in that perimenopausal period. And so instead of looking at having someone go postmenopausal and then we replace the hormones, being like, hey, let's just try to delay and more gradually go through that perimenopause, postmenopausal. This is a tidbit from myself that I just wanted to share about shared decision making. So this is something I try really, really, really hard to do with my patients, and I think it's really difficult, and it's difficult for me. I think it's difficult for a lot of physicians to get it right on both aspects, because the idea is that you have a relationship with somebody that you trust enough that you can have honest conversations with them. And I think some providers look at shared decision making and they look at it as, I'm just letting the patient do whatever they want and I'm not providing any guidance. And I think some physicians look at physicians or providers who they're just telling me what to do and there's no shared decision making. And I don't think either of those are a good situation. And the idea is that you can come to some kind of common ground, or you trust your provider enough that you understand that everything they're telling you is what they know to be best, and then they're trying to give it to you in your best interest. But also as a provider realizing yeah, I have all this data, but I also told you guys 100 things about why it maybe wasn't perfect, and that's real life. Some interesting things, I know a lot of labs will do hormone draws and tell you, oh, your level's about here, we should up or down or that. So I have a lot of experience. I have a little experience doing this, not a ton, truthfully. I have a lot more experience in gender affirming care. So when I was in Colorado, I did more gender affirming care. And when we treat to hormone levels for those folks, it's interesting because I very rarely did hormone levels. When we look at laboratory values and averages for people, what is normal is, hey, we took a whole group of people and we checked their blood and they all said they were normal, and so we used their levels and we said that was normal. And I'm like, well, were they normal, or is that normal? So there's some things that we know really well because we've done millions and billions of lab values and we see what happens in the human body in a physiological state. A calcium of 14 is not normal, it's not good for anybody. Estrogen, progesterone, testosterone levels, we don't have quite as much of the same data on that. And so I'm a pretty big advocate of treating to symptoms. So if I have somebody, and I think I've probably had this conversation, I don't know if anybody in this room, but for sure with some of my patients that who ask me about hormone levels, I sometimes say, well, how do you feel? What do you want to be different? How do you feel? And if we start those hormones, how do you feel now? Are those things better? Are they different? Because if your estrogen's 40 or it's 60 or it's 20 and you feel terrible and the same the whole time, I don't think that there's really any reason to have the risks of estrogen on board. And so I think it's just really important to it's okay to be educated. It's okay to Google. It's okay to look things up and ask questions, but we just want you to be able to have that relationship with your provider where you can, talk to them about it and understand. Yeah, and that's most of it. I don't think I left out anything major. I can give you scripts of paper if you want to write questions on them. So.